My particular research background, my PhD at UCL was on advanced care planning in dementia. Clinically, the end-of-life care strategy said everybody should be offered the opportunity to advance care plan. And working with families affected by dementia, I just was really interested as to how feasible, how practical was that. But that's some time ago. And now when we start to look at advanced care planning in dementia, in light of COVID-19, there's a sort of a growing sense of urgency that families should be supported to advance care plan for end of life. Now, I think advanced care planning always still is the elephant in the room, and we still have a very small number of people with dementia that have actually developed an advanced care plan. Probably got an increase in the numbers of people that have considered lasting power of attorneys, or advanced decisions to refuse treatment, or do not resuscitate orders, but that's not necessarily the same as an advanced care plan. So in a way, in the dementia world, we were still battling with getting people to just think ahead, to think about their wishes and preferences for the future. But it's an elephant in the room that we can't ignore anymore, really. So I just wanted to recap on what we mean by advanced care planning. And I was fortunate enough, I don't know whether it's fortunate or not, but I was on the NICE Dementia Guideline Group. And NICE make recommendations based on evidence, as you probably know. But interestingly, there's still very little evidence as to the effectiveness or the outcomes to advanced care planning in dementia. We still don't really collect data very much to say how well. We know we can count how many people have them or don't have them, but we don't know whether they actually influence better end-of-life care or not yet. But nevertheless, in principle, NICE recommended that we should offer early and ongoing opportunities for people with dementia to discuss what their wishes and preferences might be for the future. But I think that it all becomes a bit different, as we were talking earlier about services being different. Advanced care planning is probably very different in light of COVID too. When we look at advanced care planning, obviously the more advanced the dementia, or the greater coexistence of frailty, disability or comorbidity, is likely to make that event become more of a reality, and also more imperative to actually engage with the family to discuss what their wishes and preferences might be. And we know, or we espouse, that to support advanced care planning, it's done within a relationship context, so the professional gets to know the family better. They have time to explore the wishes and preferences. It's a difficult conversation to have, and it's, we have always understood that it's not one you can have with any sense of immediacy. It's not a one-off thing. It is something that you develop over time. But where does that fit with COVID-19? We no longer can rely on the principles that we'd already decided were the main factors for developing an advanced care plan. So these are the transition points and the certain healthcare events that we've always thought were the main preemptors of talking about advanced care planning. So we've always professionally had this notion, don't worry, we have time. We have time to think about it. Some people experience dementia over many years, and we can slowly adapt our conversations. If they're not ready at the outset, then we will take some of the cues that we can have from these different transition points or different healthcare events. But I think that that's troublesome. Certainly when I was recruiting participants, I was going to memory clinics. I was sitting in their clinical meetings and sort of prompting the multidisciplinary team and saying, actually, that family sounds suitable for the dyad interview that I want to undertake. I want them to talk about, their wishes and preferences, and does the carer understand what those wishes and preferences might be in light of the fact that many people haven't had a conversation. But there was a lot of professional gatekeeping as well as carer gatekeeping. So there was one particular instance that comes to mind where this particular couple seemed ideal. The care team said, no. Whilst he's very early in, he's just received his diagnosis, he's very early in his dementia, we don't feel he's adapting well to his diagnosis. So no, just hang fire a bit. 3 months later, they said, yeah, everything's fine now. We'll allow you to approach him to see if he's interested. He'd lost capacity. He'd lost capacity to undertake that, to be part of that process within 3 months. And it was because it's a difficult conversation to have, and the professionals gate-kept and felt it was too difficult for him at that time. But how much more difficult is that now in the face of a pandemic COVID-19 outbreak? I think that we recalibrate, we look at what we're thinking differently. And because we've not got this sort of indeterminate length of a journey of dementia, and at what point, do we offer advanced care planning, there's this imperative, this feel now that, crikey, we need to get on with this, because they could get coronavirus tomorrow, and we need to understand what their wishes are now, today. I think when we look at the prognosis in dementia, it's difficult, and I think that's why we struggle with talking about advanced care planning, because we don't know when the end of life care will need to be decided. When do we shift the goals of care? What are the prognostic indicators of somebody advancing through that trajectory? And I think that there's a lot of treatment uncertainty already in advanced care planning for dementia. What is the right treatment at the right time, in the right place? We also know that there's relational uncertainty, who should do what and when. And certainly we still have no real shared understanding of who actually takes responsibility for advanced care planning to facilitate advanced care planning for people with dementia. And when is it done? As well as who is it done, and in what setting, what care setting should it be delivered and by whom? And there's a lot of pontification. Should it be the GP? I mean, we're expected to understand that the GP knows families very well, but a lot of the families that I've worked with over time, they often don't see their GP very regularly at all until they actually get into retirement, start to get an age-related condition or dementia, and that might be the first time that they're actually really regularly seeing their GP. So we can't assume that the family practitioner knows them well. But again, pandemic COVID-19 throws that into massive uncertainty. In a way, we're uncertain about what's going to happen to individuals, and we're uncertain about some of the disease course of the coronavirus. But nevertheless, we're sort of panicking and thinking there's an imperative. We need to get on with that. So I think it's very interesting that we recalibrate our focus and sense of immediacy for some of these things, and the same with advanced care planning. I think that what is going to happen is that potentially there's going to be several issues, and it's more likely that we can no longer afford time. We can no longer afford that advanced care planning is going to be in this nice, soft, comfortable, relationship-centered approach that we previously talked about. It may well be over the telephone, and it may well involve other technology, which might bring additional challenges, not just to professionals, but to families also. There may be the need to hold such conversations in one sitting. It might not be something that we nicely develop over time. In talking to my palliative care colleagues, particularly at UCH in London, they're having to have palliative care conversations and advanced care conversations within 20 minutes, within immediately seeing somebody. And they're having to sort of have these conversations that actually, it's quite likely you're not going to recover from this. What can we do for you to make you more comfortable? They don't feel comfortable holding those conversations, but we might have to be in a similar position ourselves and having those conversations with families affected by dementia. I think we, like I said, we have problems discussing the possible effects and prognosis of dementia, but now we're going to have to embrace another condition. We're going to have to embrace the pandemic coronavirus. But also I think that treatment preferences may be a bit more difficult to consider. And we sort of have this lifeboat ethics at the moment, where we've got the BMA and NICE and the British Geriatric Society starting to give guidance to people in almost how they should triage and ration access to interventions. So it might not be a case of us discussing practically what somebody's wishes and preferences might be, because they may not be valid in the scheme of things when such things are being brutally triaged, really, and almost like a lifeboat type scenarios. Who do we save and who do we not save? And certainly there's been a lot of challenge about how we're using frailty measures to actually be part of the assessment to decide who gets some of the more technical interventions like intubation and ventilation. And we know that people with early stages of dementia could potentially fall foul of the rating scale that is being used for frailty. They might sort of falsely appear more frail than they actually are, which might mean that they're then restricted to some of these interventions. But nevertheless, we do need to have the conversations. And I used to use this slide really on tips on how to support advanced care planning. And many of the elements that I talked about, like giving the person time, exploring values and preferences, doing it face-to-face, all of those good practice points have been disfigured by COVID. So now that, you know, we may not have the time to have to make it a conversation that happens over time, we might need to really help families to recalibrate their wishes and preferences in terms of the disease that, you know, they might get, particularly if they're living in a care homes. We can't necessarily do it face-to-face anymore. It might be that the person with dementia is on their own, they're in isolation for whatever reason, which means that we can't have a comfortable group of people around them to support them when you've left the conversation. We might not be using the semantics of their familiar language. We might actually be using different semantics, the semantics of a pandemic, the semantics of ventilation, the semantics of acute respiratory failure. We need to take all of those things on board when we have these conversations. And as with the webinar that we're holding now, we have to consider the environment at a distance. We have to try and make sure that we give that person the best possible stab at an advanced care plan, given that there's a lot that we cannot influence in terms of environment and lighting and access. And also, one of the things that's really important is nonverbal communications. We use that an awful lot in face-to-face interviews and face-to-face advanced care planning with people. But if we're going to be doing this over the phone, we have to think of very different nonverbal cues, very different sort of responses that might indicate distress or a failure to understand. So we have to change our practice in this also. But one of the things that I often say is that there's a lot that we can use, and particularly they might be the ways we actually enable a person to know that we are actively listening. We are asking one question at a time. We are mirroring what they're saying. All of these things that we do as a matter of, I don't know, instinct really, but we just have to be much, much more tuned into that with telephone interventions and video conferencing interventions. And again, we can still rely on the many communication models that we have that help us to fully address and consider these things, but also have a beginning, a middle and an end, so that we can actually carefully and thoughtfully round up these conversations by summarising and ensuring that we do have some kind of understanding and agreement. But again, it's new territory. And rather than, it's just one of those situations where we just have to grasp this nettle and get on with it.
It was great talk. I think it actually, a lot of the kind of the core principles of how to actually have those conversations are very similar to the kind of conversations that we would have in the memory clinic as well. A lot of the issues around advanced care planning come up as issues when people are diagnosed first with dementia as well, in that setting. And I suppose that's a very controlled and I suppose very, very appropriate environment for those patients, whereas in the emergency resus room, it's very much a very different environment. So I can appreciate the challenges that are had. I suppose we've had these issues ourselves, and it isn't advanced care planning that we're actually engaging in. It's something else. It's very much around making an anticipatory care plan for when somebody comes into hospital. It's a different process, I guess.
Yeah.
I suppose I'm not sure yourself what you think about whether it really can be called advanced care planning anymore when it's in this sort of setting. As I said, that is the principle.
I think that's a good point, and I think that we have so many different terms and expressions that are under this big umbrella of advanced care planning, and I think that a lot of professionals are confused as to which term applies to what, let alone what families and lay people might think. One of the things that we did at Dementia UK is that we developed, we co-produced guidance and a template for advanced care planning, and looked at the language, looked at descriptors of what each might mean, in a very layperson way of looking at it. And we co-produced that with people with dementia and carers and other stakeholders, whether that be a will writer or a palliative care consultant, whoever, any of the stakeholders, because again, it feels like the sort of COVID-19 panic. Everybody's looking for the holy grail of advanced care planning. That's a document or a process or something that's just going to do it. But I think that sometimes you just have to get on with it, and you do the best you can.
Yeah. So, yeah, absolutely. Yeah.
So yeah, but I thought my approach was we can't develop this or do this to people. We have to develop this and do it with them. So we're not just co-produced what this little beastie looks like, and you can go onto the Dementia UK website and see it, but also in developing a sense of what skills and knowledge do people who are supposed to facilitate these things, what do they need to give them confidence. So we sort of did it in a sort of a double-pronged approach. My next plan would be to see, do they work?
Of course, yeah. But you're right. I suppose it is a question not only of what the content is and how it's actually constructed, how it's framed, the planning process. It's who's doing it and what their perspective is and what their view on the patient may be. And it's that snapshot in time can be very challenging because it may not reflect the patient truly at all. They may not be in a position to really engage in that conversation. They may not be able to reflect on it for any period of time whatsoever. And the patient themselves may not be able to really be able to be given any real meaningful information on what is being discussed and what is being made in their name, I suppose.
I think that, well, certainly that worried me, and that's what the main part of my research was about, because if we're not offering people with dementia at the right time the opportunity to think and talk about these things when they can, we often then assume that family members, because they've lived with the person for so long, automatically know what their wishes and preferences might be. And I doubted that. I couldn't hand on heart say that I felt that was accurate. And what I found was that family carers it was no better than chance, their ability to accurately predict what the person with dementia would or wouldn't have wanted. But in every interview that I did afterwards, the carer said, "Did I get it right?" So my response was, have the conversation, talk about it. I can't say, you talk about it. But I think that what COVID is, and advanced care planning, what it's done for me is that the rhetoric that we talk about, or what we talk about in advanced care planning is, if you live long enough and you're unable to eat, drink normally, if you are unable to recognise, you're immobile, you have a heart attack, you've got pneumonia, those real basic stuff. But what we cannot mitigate against, or is definitely difficult to mitigate against, is some of the, untoward things like COVID-19. How can you possibly put everything that's you need to think about within an advanced care plan and think you've got it done?
Yeah.
This has really brought that home to me, that, we're just scratching this. Are we really advanced care planning, or are we just playing at it?
Yeah, no, that's really the issue. It remains to be seen, I guess, really. The frailty, the use of frailty in particular here, to try and rationalise who gets access to, as you said, more interventional treatments. There are lots of questions around whether somebody presenting acutely unwell, whether one can really get a true picture of them within an emergency setting within a very limited period of time. And again, it's the lack of maybe perhaps training in kind of frontline emergency department staff at all different levels. That probably is coming home to roost to some degree, the fact that the resources and the time haven't been put into training people for these issues, and that if you look at the amount of time that people spend during their undergraduate training and postgraduate training in relation to older persons care, in relation to palliative care, in relation to advanced care planning and understanding what it is as a concept, is minimal compared to the amount of time they spend with older people. They're the majority of their workload for most people.
I think it's quite scary, actually. Now we start to see how some health services are being rationed, and I find it scary. I'm 62 years old. If I was in an A&E and the next person was a 32-year-old and I'd got SARS and they'd got SARS, where would I fit? I think that it's quite scary, because we're seeing ageist, we're seeing ableist society. It's quite scary, really.
It is, yeah. And it's that sense of that's an eyeball test in some ways. People are just being kind of looked at, and a judgment is being made in a very snap fashion.
And maybe some decisions do need to be made speedily, but to crassly say that a clinical frailty score is going to be part of your holistic assessment, like you're really going to have the benefit of a holistic assessment in whether you ventilate somebody or not. It's the same, with like an advanced care plan. You can have this lovely holistic advanced care planning, but when push comes to shove, you've got to make a decision. Do you want this treatment? Well, would you accept this treatment or not? Because that might not even be offered now.
And that's the actual reality on the ground, that people aren't even having that opportunity to say whether they wish to accept it or not. It's a sign of, I suppose, a very stretched and beleaguered healthcare system all around the world, not just in Irish or the UK health system.